The following podcast is part of a certified educational activity titled Unlocking the Potential of Long-Acting PrEP to Halt HIV Transmissions. Access the entire activity and complete the post-test at peerview.com/JBU860. Downloadable slides and practice aids are also available.
Hello, my name is Allison Agu. I'm a professor of adult and pediatric infectious diseases at the Johns Hopkins University School of Medicine. I'm excited to talk with you today about PrEP. Our goals today are several-fold. So first, it's to augment your knowledge of the efficacy and safety of long-acting PrEP using clinical trial data. But also, it's to equip you with strategies on how to determine potential impact of long-acting PrEP on attaining 2030 targets and providing guidance on scaling up long-acting PrEP use in your environment. We're going to talk about 2030 HIV elimination targets and the current status of PrEP. So this is the Ending the HIV Epidemic Framework in the United States that was established in 2019, and the goal is to have these targets by 2030. Importantly, we go from diagnosis all the way to response, specifically making sure that individuals who are living with HIV are diagnosed, because without diagnosis, you can't actually implement treatment or prevention. And then treatment for those who are positive, and prevention, which to date has been oral pre-exposure prophylaxis or PrEP for key populations. And last but not least, responding to potential threats and outbreaks. Another goal of the Ending the HIV epidemic strategy was to scale up HIV prevention and treatment strategies by advancing health equity. EHE has been tremendously successful in that they've decreased infections by 12% between 2018 and 2022. In the prior slides, we talked about oral PrEP as part of the EHE strategies for prevention. I do want to highlight there is more data coming and trials on vaccines as well as long-acting PrEP. So HPTN, or HIV Vaccine Trial Network, and HPTN, or HIV Prevention Trials Network. And what you see in this slide are the several pretty large, several thousand individual studies looking at vaccines that to date have not had a slam dunk, where we still see HIV incidence higher or equal or unchanged between the vaccine arm and the standard of care arm or no vaccine arm, placebo. 083 and 084 did show significant differences between incidence in the trial arm versus not. With oral PrEP, unfortunately to date, we have not had significant uptake. When we look at the left side of the slide, what we see is that our targets are 1.2 million individuals are estimated to benefit from PrEP. We've had increases, successful, sure, but still only 36% of individuals who could benefit from PrEP are on PrEP. You may or may not know there's significant differences or disparities in acquisition of HIV, with certain populations having higher HIV incidence. Unfortunately, we see those same disparities playing out with PrEP uptake, with significant differences in the uptake of PrEP in Black populations and in women, and there are also differences regionally. For example, in the South, for every one individual who has a new diagnosis of HIV who's a white person, 27 are on PrEP. Comparatively, when an individual who's diagnosed who's African American or Black, there's only 4 individuals who are on PrEP. So significant PrEP need to use disparities in those populations. When you look at PrEP uptake, daily oral options I said to date are FTC or TDF, which is Truvada, and FTC or TAF or Descovy. They're the options that are available orally. And then on-demand PrEP is not FDA approved in the US, which is a 2-1-1 strategy, 2 pills and 1 pill and 1 pill, not approved, but a potential option. And then there's injectable PrEP, which again, we'll talk about in subsequent modules, which to date is cabotegravir given every 2 months. And I am shot every 2 months. And then lenacapavir, hopefully later this summer, we'll get data on or approval from the FDA. But what you see here is that there has been increase in PrEP uptake from 2013 when it first became available to where we have 2023 data. Most of that is oral PrEP, branded and unbranded, and then Descovy, the new PrEP, and then some small increases in cabotegravir, but a long way to go. So why is that? Taking a pill every day is challenging. This is data actually from adolescents living with HIV about their adherence concerns or challenges with treatment. But I imagine this would be similar for PrEP as well. And as you see, this is a real world. Everything from I forgot, 63% reporting that they forgot, all the way to stigma, 40% presenting or reporting stigma to 25% running out of pills. So oftentimes those prescriptions are given a 30-day supply, and then you have to get refills. If you can't get to it, you may not be able to come back and get it. So again, challenges for oral pill adherence on a daily basis. This is a study actually in young men who have sex with men, specifically about PrEP. And what I want to point you to is there's not just individual challenges, but there's interpersonal challenges, including stigma and concerns. There's community level. How acceptable is PrEP? How acceptable is your sexuality? What's the influence of the healthcare you have available to you? And then there's societal and structural challenges, from everything from the facility you can go to your insurance and your access. And these are some interesting and very illuminating statements from qualitative studies. So sometimes my phone doesn't remind me, and then I won't remember if I've taken it or not, and therefore you may forget your oral PrEP. So why do we need long-acting PrEP? Daily oral PrEP is absolutely effective for preventing HIV acquisition, but its uptake and its success varies across populations and across individuals. Long-acting options could be beneficial for a number of reasons. So number one, the stigma of having to take a medication, including a medication you have to take daily, the unexpected or unplanned sexual encounters that happen with life. There's travel, especially when there's time zone changes or you're just not where you're supposed to be to get that refill or to go back to your doctor. There's challenges, again, with daily pill adherence, and that's everything from actually getting the pill in your mouth to the psychological impact of taking a pill. And last but not least, it is critically important to provide people with options and choices to have PrEP the way they would like to that matches their lifestyle. So, the take home, having a choice is important. Daily oral PrEP is available. Long-acting PrEP is here, every 2-month injectable. It's critical to individualize care. Select a PrEP regimen that should consider factors like choice, preference, your medical history, comorbidities, the ability to adhere to daily therapy, your reproductive status, and then your access, multi-level access. There are PrEP options that are on the near horizon, everything from long-acting, every 6-month injectable PrEP, and then other long-acting agents in development, whether they be weekly or monthly or hopefully beyond. The impact of long-acting PrEP with a focus on the PURPOSE trials. In the last module, we mentioned HPTN 083 and 084, long-acting cabotegravir every 2 months versus daily oral FTC-TDF. Let's talk about this a bit more. So in these studies, both HPTN 083 and 084, long-acting cab proved superior to daily oral FTC-TDF. HPTN 083 first, over 4,500 men who have sex with men and transgender women. There were 7 incident infections with on-time long-acting cab injections, and a 66% reduction in the risk of HIV acquisition with long-acting cab versus daily oral FTC-TDF. Critically important to underscore that with increased adherence to oral FTC-TDF, there was decreased incidence. So it was a matter of adherence more likely. For 084, over 3,200 cisgender women, 0 incident infections with on-time long-acting cab injections, and 88% reduction in risk of HIV long-acting cab versus daily oral FTC-TDF. Long-acting cab was approved for PrEP in December of 2021, and we've seen uptake slowly happening. Let's talk about PURPOSE 1. PURPOSE 1 was a study of lenacapavir, a first-in-class novel capsid inhibitor given subcutaneously every 6 months for HIV prevention. PURPOSE 1 studied cisgender women in South Africa and Uganda. This is a study design comparing lenacapavir versus FTC, TDF, and then FTAF. Importantly, for PURPOSE 1, the median age, it was young, 21 in the arms. 99% Black, given where it was located. And what you see is some increase or high rates of syphilis, chlamydia, gonorrhea. So risk for HIV acquisition. Very, very little PrEP or prior PrEP use. And while people had prior HIV testing, again, very little PrEP use previously. At IAS, when this was presented, there was a standing ovation as there were 0 infections in the lenacapavir arm compared to 39 in the FTC-TAF arm and 16 in the FTC-TDF arm. Again, 0 infections. And when compared, lenacapavir had significantly lower acquisition risk or incidence than background or either of the oral PrEP arms. This is PURPOSE 2, As I said, Purpose 1 was among cisgender women. Purpose 2 expanded that internationally, double-blind, randomized phase 3 trials in men and gender-diverse populations. And what you see, similar design, but only comparing to FTC TDF. What you see here is, again, large sample size, median age about 28 in both arms. Non-white race actually significant. I've talked about in prior modules that the disparities in HIV acquisition. And so non-white race, 67%, 68% in the arms, and a significant amount of Hispanic and Latino. And what you see, again, gender diversity was clear. High potential risk with STIs, with chlamydia and syphilis. Significant number of individuals had never had a prior HIV test, and prior PrEP use only about a quarter. There was also high rates of stimulant use, and that's important because that can increase your risk of HIV acquisition. There was significantly fewer rates of acquisition of HIV in the LEN arm, only 2 infections compared to the FTC TDF arm and to the background incidence. So when you look at both Purpose 1 and Purpose 2, the main side effects are injection site reactions in the form of nodules or pain or swelling. And the severity of those injection site reactions, or ISRs, decreased over time, but were present. And what you see in the green are individuals who had none, and then the purple and the orange are the amount or the numbers of nodules and pain, again, which decreased over time. For patients, only 4 in Purpose 1, and 26 patients in Purpose 2 actually discontinued because of those ISRs. So what's the summary? HPTN 083 showed CAB, long-acting CAB, was superior to daily FTC TDF in preventing HIV infections in MSM and in transgender women. 084, CAB also outperformed FTC TDF in cisgender women. Purpose 1, LEN showed high efficacy in young cisgender women. Again, 0 infections. Purpose 2, LEN is highly effective in men who have sex with men and transgender women. So what are the implications for long-acting PrEP? Even wider dosing intervals, twice yearly dosing, so you have to think about it less. Could benefit even more PrEP candidates and more PrEP users. Demonstrated efficacy across important populations, making long-acting agents accessible to a lot of PrEP candidates, people who may want it but not want it orally and want to think about it differently. Real-world data is needed and will be important to actually optimize the uptake and the use of these long-acting targets. But we'll talk about the real-world implications of long-acting PrEP. So this is a search trial which talked about and looked at dynamic choice for HIV prevention versus standard of care. In the study in Kenya and Uganda, investigators evaluated the proportion of time covered by PrEP when individuals were given choice of PrEP that they could change over time versus giving PrEP or PEP without choice or other supports that were available in the dynamic choice arm. So PrEP, oral PrEP, or long-acting CAB added later were the options for the dynamic choice arm, and then PrEP and oral PrEP provided in control group as standard of care, and PEP post-exposure prophylaxis. And this is an extension of 3 randomized controlled trials. So in the first phase of this study, 30 to 40% increase in prevention when people were given choice and the option to change that choice versus standard of care. In the long-acting CAB extension phase, there was a 56% increase in prevention coverage when they were given, again, choice versus the standard of care. So what the search trial showed was having a choice actually increased PrEP use. So long-acting CAB did not just replace oral PrEP for people using oral PrEP, but actually led to uptake of PrEP. Over the course of the trial, 56% of people used long-acting CAB, 53% used oral PrEP, 2% used post-exposure prophylaxis. There were 7 incident HIV infections in the standard of care arm, and again, 0 incident infections in the DCP or dynamic choice arm. Again, giving people the option to choose how they PrEP, when they PrEP, increased uptake and decreased incidence. So of those initiating long-acting CAB, 43% had not been using any PrEP in the prior month. The DCP didn't just shift their use of PrEP, but actually increased the uptake of PrEP and the overall number of people using PrEP. So perspectives of long-acting PrEP among men who have sex with men who were non-adherent to daily oral PrEP. I told you we see uptake, but we know adherence is a challenge. So when we asked individuals in this study what were their perceptions of long-acting PrEP in interviews, in qualitative in-depth interviews, what their perspectives were. There was lack of knowledge about long-acting PrEP, and they wanted more information, but they were motivated to learn more, particularly as they'd had challenges with PrEP. So interested in PrEP, but challenged with oral PrEP. They wanted to learn more, and they were absolutely open to considering those novel PrEP formulations. They were not interested in being the first to try something new, right? So that's actually important. But they would like fewer clinic visits, general access, and better coordination with their regular visits. So not burdensome. How can we make it easy for individuals? And there was some concern over insertable or implantable or retained options. These things are important to understand how people would like to PrEP and what may actually work. The deprivian ring, which is not available in the US or DVF, is another option for PrEP in other parts of the world. And how does it work? It is a ring inserted into the vagina every month and slowly it releases deprivian into the body to help prevent HIV at the local site. Doesn't expand to other parts of the body. And it works to prevent HIV individuals who are HIV negative in the same way that a PrEP pill may do. It is flexible silicone, insertable, and again, it was developed by as a sort of a microbicide. It only works to prevent HIV, and in some of the studies I showed you, there was significant other STI acquisition. So this is solely for HIV prevention. Why is it good? It's about options. So women bear the burden of the global HIV/AIDS burden. In the US, we have more men. In the global South, it's more women that acquire HIV. It is discreet and it gives people control. Women have control of what, when, and how they PrEP. There may be fewer side effects as it doesn't extend to the whole body. Easy to use, and it does work really well. Not perfect, but you also don't have to take a pill every day and remember to take a pill every day. Again, this is about choice and options. We've talked a lot about the challenges with uptake, and I asked you to think about, as you went through these slides and the modules with me, about what would it take for PrEP to be optimized in your setting. So one, we need local champions, and I'm hoping all of you watching will become local champions. So one, identifying the challenges. There are oftentimes a lack of personnel who is responsible for the PrEP management. So who could that be in your setting? There's inconsistent PrEP support and buy-in from clinic leadership. How can we do that? And there's difficulty retaining patients on PrEP. So what are the ways that we can do that? So the solutions: designated PrEP champion. Can you be a PrEP champion? Strengthen communication with your leadership. Use proactive approaches to increase PrEP retention. And then train providers and PrEP champions to meet patient needs and literally meet patients where they are. What are the real-world implications of long-acting PrEP? Dynamic choice. In a study that offered a choice of oral or injectable PrEP, as well as streamlined counseling and access to PrEP champions, there was increased uptake and persistence of all types of PrEP. So choice. 2, it's important to review options with individuals. So by sex, gender, patient preference, their medical history, what's their life like, what is preferable to them. PrEP candidates and people who may be eligible for PrEP may not know all the options that exist. So we shouldn't presume, and we should have conversations and educations about PrEP. Super important to do that. And then utilize beyond yourself. Who are the PrEP navigators and the other people in your setting that can be helpful to assisting individuals in their PrEP journey? The deprivian ring, not available in the US as an option, but is a long-acting intravaginal ring that is available in areas of the world where cisgender women can benefit from their use. So thinking about all of the options. The future of PrEP to end HIV transmission. When we think about PrEP and the needs to optimize PrEP, it's first important to think about what is your population that's at risk and who may benefit most from PrEP. So the proportionate risk, and then align that geographically, temporally, to make sure that you have the best options available. This UNAIDS model is one way to project how, who, and what you may need. So beyond that, it is then now important to improve the conversations about PrEP. Most importantly, we have got to normalize PrEP as a prevention option for any person who is or plans to be sexually active and may be at risk for HIV. So initiate the conversation about PrEP, but we also have to initiate the conversation about sex, right? Avoid stigmatizing language. Build rapport and trust. Provide person-centric care. It's about the whole person before you get to what they're doing sexually and how their PrEP needs may or may not be. Promoting cultural competence and humility, not assuming and asking, and then building that trust and rapport and that patient-provider or person-provider relationship. Making sure we set up safe clinical spaces that include offices, community, going beyond our hospitals and doctors' offices. How do we get PrEP to be more talked about beyond those spaces? Promote representation of racial, ethnic, minority, transgender, and gender diverse individuals. Display signs that show acceptance. Pride flags or other things. Displaying pronouns, mine, she, her, and hers. Provide private consultation areas, and even beyond our clinic spaces to telehealth areas and virtual spaces. Integrate both sexual health and harm reduction in your practice to facilitate the conversations about PrEP. So when we talk about the HIV prevention pipeline, it's exciting. In development, in preclinical and clinical trials, everything from long-acting implantables to preventive vaccines to douches, mucosal inserts, and broadly neutralizing antibodies. Many things in the pipeline. And in development and in efficacy trials, a weekly oral PrEP, combination oral pregnancy prevention, and PrEP options. And then soon to be approved, hopefully this summer, will be twice yearly lenacapavir, which we've talked about. And then there's some newly approved or recommended strategies, including injectable cabotegravir and the pivirine ring, which is conditionally recommended by the WHO. So exciting times for prevention. There are PrEP products, again, in preclinical and clinical development, long-acting oral agents, which could provide HIV protection with less frequent dosing. Again, when you think about those challenges with adherence, one of the top reasons was, I forgot. Well, if you don't have to take it daily, then you don't have to forget daily. And then we'll have to think about creative ways to make sure people remember that weekly or that monthly medication. But that shouldn't be reasons why we don't develop them. Longer-acting injectables, there's promising PK for even once-yearly options, and some of those studies are in development. And then there's multi-purpose rings that could do more than pregnancy prevention, but PrEP and other things. And then vaccines. I told you in Module 1 that we don't have a home run for vaccines yet, but that doesn't mean we don't stop trying. And then last but not least, innovative delivery methods, such as self-injectables, which I think could be a game changer. Self-injectable, so you don't have to come to clinic on a regular basis to get that shot. And then vaginal films and other things that could, again, be non-oral options that meets people where they would like to be for their PrEP and prevention. And then again, PrEP products with efficacy trials underway, daily, weekly, monthly oral agents for those who don't want a shot. Monthly oral PrEP and development, potentially offering, again, safety profiles that may reduce side effects that are compared to other tenofovir-based regimens, but again, meeting people where they may need to be. And then combination oral contraceptive and oral PrEP, dual-purpose modalities, whether they're oral and maybe subsequently injectable could potentially be, or implantable may be on the horizon. In terms of long-acting PrEP, there are studies underway for oral NRTTI, or oral nucleoside reverse transcriptase translocation inhibitor, particularly MK8527, for PrEP. It is being investigated for once-monthly oral PrEP, oral dosing for PrEP, and also once-weekly dosing being studied for HIV treatment. Importantly about this drug, it was similar to islatravir, same class, but different drug. And I say that because islatravir was stopped because of some CD4 changes. But this study is underway, or studies are underway, to look at this drug for oral long-acting PrEP options. So stay tuned. Dose finding and other studies are underway. So in terms of dual prevention products, or dual prevention pills, or DPPs, oral contraceptives and PrEP, this is considered a multi-purpose preventive technology. And efficacy trials may not be required since each drug combination has already been studied and FDA approved. So bioequivalency data of the two approved products, FTC, TDF, and the progestin or just progesterone estrogen products dosed together is likely, and that will be needed. So these may be 28-day regimens, which consists of 21 pills, PrEP COC, and then 7 PrEP pills only. But again, similar product that's already on the market. People are used to that the little circle of pills and would then fit into prevention strategies. So what are the future PrEP options? I hope I've raised your excitement. They may include combinations therapies, PrEP and oral contraceptives, longer acting, weekly, monthly options, injectable options, implantable options, self-administered injections, BNABs, and hopefully vaccines. Expanded PrEP options will only allow for further personalization based on an individual's preferences, their needs, their desires, their risk, and their evolution of life, meeting people literally where they are, where they may be going.
First of all, um, okay, I'm gonna start off like this. I got married in 2021, December 22nd. Okay, the guy who I married, okay, this lady he was with, she had HIV. She exposed it to him, but she died, and so they called him and told him that he needed to go to get tested. Okay, so when he went to get tested, he was positive with HIV, and he hid it from me. I didn't know, and he was taking medicine. And I said, we get together, I talk. I say, have you ever, take no kind of medications or nothing like that? I said, because I take pressure pills, stuff like that. He said, no, I don't take anything. He lied to me. So one day they delivered his medicine, and I found it. And I called my niece and I said, what is this? What is Victoria? I said, what is that? She said, oh, that's HIV medicine. And I was so mad, I cried, and because we got married, I cried and I said, "Oh no!" I said, "I cannot be with you. I can't be." So what I did, I started going to camp because one time I had hepatitis, so I started going to help, and I'm clear from that. So and I was just telling her my story about him, and so she said, "Well, how about if you want to try some PrEP medicine that'll keep you, from getting HIV?" I said, "Well, I thought, Lord," and I said, I'm gonna try it." I said, "I'm gonna try it because I don't want to. I don't want it. I don't want HIV."
I work in the HIV field and I heard about PrEP. We offered it to some of our clients. I went to some conferences and learned about it. And one day I just went to my doctor and said, "Hey, would I be a candidate for PrEP?" And she said, "Yeah." Well, we went through a whole sexual history taking, and she said, "Yeah, sure. If you want to get on PrEP, we can do that." I wanted to get on long-acting PrEP, but I couldn't at first. She asked me, could we do the pill version first? And so we did that. I didn't start it right away. I took about 30 days that I sat with the medicine before I even took it. But then I started taking it. So my doctor, she wanted me to take that medicine first because she didn't want the insurance companies to say like, "Oh, you didn't try that option first." So we did that for a few months. I stayed on it. I did well, but the everyday taking of the pill kind of bothered me, and I didn't want to feel like I was taking medicine every day, and I don't take medicine for anything. So she said that it would be good if we went ahead and transitioned to the long-term injectable PrEP, which was great because I didn't have to take the pill every day, and I would go to the doctors, get the shot, and then I would go on about my way.
Well, I think for one, I hate taking pills. So that every day taking the pill was just a little bit too much for me. And sometimes I forgot and and then I get in a panic. So I just, when I heard about the injectable version, I thought like, this is much simpler. It's like every 2 months, that way I don't have to think about the pill. And then it's just more convenient to get it. So I looked it up, I did some research on it, and then I asked my doctor to prescribe it.
So what I like about the injectable version is I don't have to go and pick up a prescription. When I go in for my doctor's appointment, it's pretty much a one-stop shop. I go in, outside of the labs that I have to take, but that's before I go into the doctor's. So with the injectable PrEP, I just go in, I get the injection. I don't have to go pick up a prescription. I don't have to worry about someone picking up my prescription bottle when I'm at home or asking me about it or questioning like, what is this medicine you're taking? And it's just something that I can do for myself without anyone else knowing about it. But I know I'm protecting myself.
I think it was easier for me because I had a great physician who she followed up consistently. She was very caring and understanding. She provided a lot of education and information about, the risks, the side effects, and how to use it. There was consistent follow-up, appointments and meetings to check in. There was obviously routine labs and tests, to check in. And if I had any concerns or worries, I could always reach out to her and easily access her as well. And so those, I think made it easier to sort of stick to it. Besides my own desire to want to use this thing as a preventative measure, but it made me more likely to sort of stick with the PrEP.
I think the only thing for me would be the amount of labs that you have to get, because you do have to still go and get tested to make sure you are still HIV negative before you get the injection. And the labs are not covered, even though it's a preventable medication that you're taking. Those labs can become costly if you don't have like an FSA or something set aside. And initially I didn't, so um, that kinda got in the way. I wasn't expecting all of the labs that I had to pay for, but the next time, FSA came up, I made sure to put the money to the side to make sure I was able to get those covered.
It's been pretty okay. There wasn't, anything out of the norm or ordinary. It was just obviously the pain at the injection site was very bad. I've had injections before, but that one is something about it that just makes it hurt for a long time. But after getting over that pain, over a few weeks or so, everything's kind of back to normal. It's pretty okay. The only other thing is obviously having to remember to go back and get it every 2 months and keeping a track of it. When I got it last, reminding my doctor to refill that prescription, contacting the specialty pharmacy to fill it, um, you know, getting labs done before getting the Truvada, getting it ahead of time so the doctor puts the order in. So it requires, I think, a lot of logistics on my end to sort of plan ahead for that versus the oral where it's just available, accessible. I can just take it and go.
It would mean less labs, and less, office visits, because with the pills, you could take them every day and at home at your discretion, but with the injections, you would have to have someone, do that for you. So it would be less, visits to the doctor's office to get that, which I find to be, very convenient. Especially if you're not going to the doctors for many other things. Just to go twice to get the injection for the year would be an amazing option, and I would definitely look forward to that.
I think that would be major progress in the medical field, and I think it will be definitely more convenient. And again, if it's twice a year, you have more time to sort of prepare for it and plan for it and do whatever you need to do. And I mean, just twice a year, I think that's amazing. I'm actually really excited to hear that and sort of looking forward to how that would even change the the scheme of things in terms of people receiving PrEP twice a year, versus like an everyday thing. So people have options. If you want a pill, you can get the oral. If you want the injectable 2 months, you can do that. If you want the long acting one for 6 months, you have a variety of options. So I think that's actually going to be very impactful.
I wish the healthcare providers would offer it more. I found that anytime I discuss PrEP, it was because something that I had brought up. A lot of people, especially women of color, um, that I even speak to, don't even know that it's an option for them. So just even saying like, "Hey, this is an option," maybe at your at your GYN visits, primary care visits, to let people know that it's an option that will protect you from getting HIV. Especially depending on certain places where you live geographically where it may be more prevalent for you to acquire HIV. I think it's really important that those providers let people know or their patients know of the risk factors that they may have, either married, single, or whatever you're doing. It doesn't really matter. The option should be to inform people when they come in of all of the medications that are available to prevent health conditions in which they are at a higher risk of acquiring.
So giving the people that option, so that, because sometimes some people feel like, oh, once I started, then I have to be on it for life, like that kind of thing. And it can sometimes be a detractor, like, oh, well, people had their own sort of hesitancies about what are the long-term effects of this, like what would it cause? And so having that option to say, I can take this injectable for 2 months or this injectable for 6 months, hopefully, right? That at least can prevent that for that period of time while, I continue through life. It's like having a safety net to sort of like back on, rely on. And I think that's very necessary. It's very important. And I definitely want to continue to advocate for that.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/JBU860.